This is the audio lecture for Assessment of High-Risk Pregnancy, Chapter 10. About 500,000 of 4 million births in the United States each year are categorized as high risk because of maternal or fetal complications. Identification of risk with appropriate and timely intervention prevents morbidity and mortality of mothers and infants. Care of these patients requires the combined efforts of medical and nursing personnel. Assessment of risk factors. Pregnancies can be designated as high risk for any of several undesirable outcomes. In the past, risk factors were evaluated only from a medical standpoint. Therefore, only adverse medical, obstetric, or physiologic conditions were considered to place the woman at risk. Today, a more comprehensive approach to high-risk pregnancy is used, and the factors associated with high-risk childbearing are grouped into broad categories based on threats to health and pregnancy outcomes. Categories of risk include biophysical, psychosocial, sociodemographic, and environmental. Make sure you guys read box 10-1, categories of high-risk factors in your textbook. Biophysical risk includes factors that originate within the mother or fetus and affect the development or functioning of either one or both. Genetic factors may interfere with normal fetal or neonatal development, result in congenital anomalies, or create difficulties for the mother. These factors include defective genes, transmissible inherited disorders, and chromosome anomalies, multiple pregnancy, large fetal size, and ABO incompatibility. Nutritional status. Adequate nutrition, without which fetal growth and development cannot proceed normally, is one of the most important determinants of pregnancy outcomes. Conditions that influence nutritional status include the following: young age, 3 pregnancies in the previous 2 years, tobacco, alcohol, or drug use, inadequate dietary intake because of chronic illness or food fads, inadequate or excessive weight gain, and a hematocrit value of 33% or less. Medical and obstetric disorders that happen within the current and or past pregnancies, obstetric-related illnesses, and pregnancy losses also put the client at high risk. Psychosocial risk consists of maternal behaviors and adverse lifestyles that have a negative effect on the health of the mother or fetus. Smoking. A strong, consistent causal relation has been established between maternal smoking and reduced birth weight. Risks include low birth weight infants, higher neonatal mortality rates, increased miscarriages, and increased incidence of premature rupture of membranes. These risks are aggravated by low socioeconomic status, poor nutritional status, and concurrent use of alcohol. Caffeine. Birth defects in humans have not been related to caffeine consumption. We do know that high intake of caffeine has been related to a slight decrease in birth weight. Alcohol. Although its exact effects in pregnancy have not been quantified and its mode of action is largely unexplained, alcohol exerts adverse effects on the fetus, resulting in fetal alcohol syndrome, fetal alcohol effects, learning disabilities, and hyperactivity. Drugs. The developing fetus may be adversely affected by drugs through several mechanisms. They can be teratogenic, cause metabolic disturbances, produce chemical effects, or cause depression or alteration of CNS function. This category includes medications prescribed by a healthcare provider or bought over the counter, as well as commonly abused drugs such as heroin, cocaine, and marijuana. Psychological status. Childbearing triggers profound and complex physiologic, psychologic, and social changes, with evidence to suggest a relation between emotional distress and birth complications. This risk factor includes conditions such as specific intrapsychic disturbances and addictive lifestyles, a history of child or spouse abuse, inadequate support systems, family disruption or dissolution, maternal role changes or conflicts, non-compliance with cultural norms, unsafe cultural, ethnic, or religious practices, and situational crises. Sociodemographic risks arise from the mother and her family. These risks may place the mother and fetus at risk. Examples include lack of prenatal care, low income, marital status, and ethnicity. Poverty underlies many other risk factors and leads to inadequate financial resources for food and prenatal care, poor general health, increased risk of medical complications of pregnancy, and greater prevalence of adverse environmental influences. Lack of prenatal care. Failure to diagnose and treat complications early is a major risk factor arising from financial barriers or lack of access to care. Depersonalization of the system resulting in long waits, routine visits, variability in healthcare personnel, and unpleasant physical surroundings, lack of understanding of the need for early and continued care, or cultural beliefs that do not support the need, and fear of the healthcare system and its providers. Age. Women at both ends of the childbearing age spectrum have a higher incidence of poor outcomes. However, age may not be a risk factor in all cases. Both physiologic and psychologic risks should be evaluated. When talking about our adolescents, more complications are seen in young mothers, those that are younger than 15, who have a 60% higher mortality rate than those older than 20 years, and in pregnancies occurring 6 years after menarche. Complications include anemia, pregnancy-induced hypertension, prolonged labor, and contracted pelvis and cephalopelvic disproportion. Long-term social implications of early motherhood are lower educational status, lower income, increased dependence on government support programs, higher divorce rates, and higher parity. The older mother. The risks to older mothers are not from age alone, but from other considerations such as number and spacing of previous pregnancies, genetic disposition of the parents, and medical history, lifestyle, nutrition, and prenatal care. The increased likelihood of chronic diseases and complications that arises from more invasive medical management of a pregnancy and labor combined with demographic characteristics put an older woman at risk. Medical conditions more likely to be experienced by mature women include hypertension and pregnancy-induced hypertension, diabetes, extended labor, cesarean birth, placenta previa, abruptio placentae, and mortality. Her fetus is at greater risk for low birth weight and microsomia, chromosomal abnormalities, congenital malformations, and neonatal mortality. Parity. The number of previous pregnancies is a risk factor associated with age and includes all first pregnancies, especially a first pregnancy at either end of the childbearing age continuum. The incidence of pregnancy-induced hypertension and dystocia is higher with a first birth. Marital status. The increased mortality and morbidity rates for unmarried women, including a greater risk for pregnancy-induced hypertension, are often related to inadequate prenatal care and a younger childbearing age. Ethnicity. Although ethnicity by itself is not a major risk, race is an indicator of other sociodemographic risk factors. Non-white women are more than 3 times as likely as Caucasian women to die of pregnancy-related causes. African American babies have the highest rates of prematurity and low birth weight, with the infant mortality rate among African Americans being more than double that for Caucasians. Psychologic considerations. Once a pregnancy has been identified as high risk, the pregnant woman and her fetus are monitored carefully throughout the remainder of the pregnancy. All women who undergo antepartum assessments are at risk for real and potential problems and may feel anxious. In most instances, the tests are ordered because of suspected fetal compromise, deterioration of a maternal condition, or both. Environmental factors. Various environmental substances can affect fertility and fetal development, the chance of a live birth, and the child's subsequent mental and physical development. Environmental influences include infections, radiation, chemicals such as pesticides, therapeutic drugs, illicit drugs, industrial pollutants, cigarette smoke, stress, and diet. Paternal exposure to mutagenic agents in the workplace has been associated with an increased risk of miscarriage. When a woman is diagnosed with a high-risk pregnancy, she and her family will likely experience stress related to the diagnosis. The woman may exhibit various psychologic responses, including anxiety, low self-esteem, guilt, frustration, and inability to function. A high-risk pregnancy can also affect parental attachment, accomplishment of the task of pregnancy, and family adaptation to the pregnancy. If the woman is fearful for her well-being, she may continue to feel ambivalent about the pregnancy or may not accept its reality. The nurse can help the woman and her family regain control and balance in their lives by providing support and encouragement, information about the pregnancy problem and its management, and opportunities to make as many choices as possible about the woman's care. Antepartum testing. Antepartum testing has two major goals. The first is to identify fetuses at risk for injury caused by acute or chronic interruption of oxygenation, so permanent injury or death might be prevented. The second goal is to identify appropriately oxygenated fetuses so unnecessary intervention can be avoided. Detection of potential fetal compromise. In most cases, antepartum testing is used for patients with disrupted fetal oxygenation. Most cases begin at 32 to 34 weeks gestation, and usually once a high risk factor is identified will continue until the birth of the baby. Some of the different antepartum testings that we do for determination of fetal well-being that's going to be discussed. We will talk about daily fetal movement count, also known as kick counts, the NST or non-stress test, the CST or the contraction stress test, and the BPP or biophysical profile. The daily fetal movement count, also called kick counts, can be done at home, is non-invasive, is simple to understand, and usually does not interfere with a daily routine. The daily fetal movement count is frequently used to monitor the fetus in pregnancies complicated by conditions that may affect fetal oxygenation. These conditions include, but are not limited to, pregnancy-induced hypertension or chronic hypertension and diabetes. The presence of movements is generally a reassuring sign of fetal health. There are several different methods or protocols used for fetal kick counting. One recommendation is to count once a day for 60 minutes. Other common recommendations are that mothers count fetal activity 2 or 3 times daily for 2 hours or until 10 movements are counted, or all fetal movements in a 12-hour period each day until a minimum of 10 movements are counted. When fetal movements cease entirely for 12 hours, this signals the fetal alarm. A count of fewer than 3 fetal movements within 1 hour warrants further evaluation by a non-stress test or a contraction stress test and a complete or modified biophysical profile, which we will talk about later. In assessing fetal movements, it is important to remember that they are usually not present during the fetal sleep cycle. They may be temporarily reduced if the woman is taking depressant medications, drinking alcohol, or smoking a cigarette, and they do not decrease as the woman nears term. Obesity, however, may decrease the ability of the mother to assess fetal movement. This is figure 10-1 in your textbook. It's an example of a form used to record fetal kick counts. Typically, when I tell a mom about doing fetal kick counts, we give them a few pointers that would make it a little bit easier to do. Usually I tell the mother to do it around the same time each day when you usually feel the baby move, or after a meal such as breakfast, lunch, or dinner, because you put a little fuel in the tank, the baby gets a little excited when the mother eats. So typically I'll tell her to eat something sweet, maybe drink a cola or something like that I'll know will give the baby a good rush of fuel. Typically, I'll tell the mom to lie down on her left side in a nice, quiet, dark room and just hold her belly and feel the amount of times her baby kicks. And then she would record it on the sheet that you see on the slide. Ultrasound. Diagnostic ultrasonography is an important, safe technique in antepartum fetal surveillance. It is considered by many to be the most valuable diagnostic tool used in obstetrics. It provides critical information to healthcare providers regarding fetal activity and gestational age, normal versus abnormal fetal growth curves, fetal and placental anatomy, fetal well-being, and visual assistance with which invasive tests can be performed more safely. Major indications for obstetric sonography are listed by trimester in Table 10-1 in your book. During the first trimester, ultrasound exam is performed to obtain information regarding the number, size, and location of gestational sacs, the presence or absence of fetal cardiac and body movements, the presence or absence of uterine abnormalities or adnexal masses, and pregnancy dating. During the second and third trimesters, information regarding the following conditions is sought: fetal viability, number, position, gestational age, growth pattern and anomalies, amniotic fluid volume, placental location and condition, presence of uterine fibroids or anomalies, presence of adnexal masses, and cervical length. Ultrasound exam can be done abdominally or transvaginally during pregnancy. With the standard ultrasound, its primary use is to detect fetal viability, determine the presentation of the fetus, assess gestational age, locate the placenta, examine the fetal anatomy for malformations, and determine amniotic fluid volume. Specialized or targeted exams are performed if a woman is suspected of carrying an anatomically or a physiologically abnormal fetus. Indications for a comprehensive exam include abnormal findings on clinical exam, especially with polyhydramnios or oligohydramnios, elevated alpha fetal protein levels, and a history of offspring with anomalies that can be detected by ultrasound exam. Comprehensive ultrasonography is performed by highly trained and experienced personnel. This is figure 10-2 out of your textbook. Here the fetus is seen on three-dimensional ultrasound. A is a full body view of a fetus at 11 weeks and 6 days of gestation. B is a close-up view of a fetal face later in the pregnancy. This is figure 10-3. The appropriate planes of sections, which is your dotted line. So HC is measuring the head circumference of the baby, and the AC line is measuring the abdominal circumference. This is figure 10-4 out of your text. It's the mid-sagittal view of a 12-week fetus showing the nuchal translucency and nasal bone. A prenatal screening technique called nuchal translucency screening uses ultrasound measurements of fluid in the nape of the fetal neck between 10 and 14 weeks of gestation to identify possible fetal abnormalities. And there's the nuchal translucency. This is table -1 in your book. This is the major uses of ultrasound during the pregnancy, and it listed trimester by trimester. Now we're going to go on to the Doppler blood flow analysis. One of the major advances in perinatal medicine is the ability to study blood flow non-invasively in the fetus and placenta with ultrasound. Doppler blood flow analysis is a helpful tool in the management of pregnancies at risk because of maternal hypertension and diabetes, IUGR, which is intrauterine growth restriction, multiple fetuses, and preterm labor because it provides an indication of fetal adaptation and reserve. Amniotic fluid volume. Abnormalities in the amniotic fluid are frequently associated with fetal disorders. Subjective determinants of oligohydramnios, which is too little fluid, include the absence of fluid pockets in the uterine cavity and the impression of crowding of small fetal parts. Increased amniotic fluid is called polyhydramnios, or the newer term is just hydramnios. Subject criteria for hydramnios includes multiple large pockets of fluid, the impression of a floating fetus, and free movement of fetal limbs. The BPP, or Biophysical Profile. This is a non-invasive dynamic assessment of a fetus that is based on acute and chronic markers of fetal disease. The BPP includes the amniotic fluid volume, fetal breathing movements, and fetal tone determined by ultrasound, and fetal heart rate reactivity determined by the means of the non-stress test. Therefore, the Biophysical Profile, or BPP, can be considered a physical examination of the fetus, including determination of vital signs, fetal heart rate reactivity, and fetal breathing movements. The main role of the nurse is counseling and educating women about the procedure. Please review this table in your textbook. It's table 10-2, scoring of the BPP, and 10-3, BPP management. The BPP is used frequently in the late second and third trimesters for antepartum fetal testing because it is a reliable predictor of fetal well-being. A BPP of 8 or 10 with a normal amniotic fluid volume is considered normal. Another type of BPP that is done also in the OB setting is the modified biophysical profile. It's being used increasingly as a way to shorten the testing time required for the complete biophysical profile by assessing the components that are most predictive of perinatal outcome. The modified BPP combines the non-stress test, which assesses the current fetal condition, with measurement of the quantity of amniotic fluid, which is an indicator of placental function over a longer period of time. The AFI, rather than the amniotic fluid volume, is often used to measure the amount of amniotic fluid present. Desired test results are a reactive non-stress test and a normal amniotic fluid index. An amniotic fluid index greater than 5 is generally considered normal. The presence of normal fetal biophysical activities indicates that the central nervous system is functional and the fetus therefore is not hypoxemic. The biophysical profile is an accurate indicator of impending fetal death. Fetal acidosis can be diagnosed early with a non-reactive NST and absent fetal breathing movements. An abnormal BPP score and oligohydramnios are indicators that labor should be induced. Again, please look at Table 10-3 for management of the biophysical profile. MRI or magnetic resonance imaging. With MRI, the examiner can evaluate the fetal structure and overall growth, the placenta, the quantity of amniotic fluid, maternal pelvic structures, the biochemical status of tissues and organs, and soft tissue metabolic or functional anomalies. The problem with the MRI is the mother has to be flat on her back for 30 to 60 minutes, so this puts her at risk for supine hypotensive syndrome. So how do you guys suggest we fix this problem if a mother is undergoing an MRI? Basically, we would put a wedge under her right or left hip to ease the compression of the superior vena cava by the uterus. Biochemical assessments continue. Now we're going to move on to the amniocentesis. Biochemical assessment involves biologic examination and chemical determinants. See Table 10-4 in your book. This deals with the procedures used to obtain the needed specimens, such as an amniocentesis, PUBS or percutaneous umbilical blood sampling, or chorionic villus sampling and maternal sampling. Amniocentesis is performed to obtain amniotic fluid, which contains fetal cells. Under direct ultrasonographic visualization, a needle is inserted transabdominally into the uterus, amniotic fluid is withdrawn into a syringe, and the various assessments are performed. Amniocentesis is possible after week 14 of pregnancy, when the uterus becomes an abdominal organ and sufficient amniotic fluid is available for testing. Indicators or indications for the procedure include a prenatal diagnosis of genetic disorders or congenital anomalies, assessment of pulmonary maturity, and rarely diagnosis of fetal hemolytic disease. Of course, there are complications in the mother and fetus. It occurs in less than 1% of cases, and for the mother, some of the complications include leakage of amniotic fluid, hemorrhage, fetal maternal hemorrhage with possible maternal Rh isoimmunization, infection, labor, placental abruption, inadvertent damage to the intestines or bladder, and amniotic fluid embolism. One thing that as an OB nurse you should know that whenever we do an invasive procedure on a mom where there's the likelihood of fetal and maternal blood mixing, for my moms who are Rh negative status, we must administer RhoGAM to those mothers after the procedure is done. These are a list of some of the fetal complications that can happen after amniocentesis. It includes death, hemorrhage, infection, and direct injury from the needle. Many of the complications have been minimized or eliminated by using ultrasound to direct the procedure. This is figure 10-6 in your book. Figure A shows an amniocentesis and laboratory use of amniotic fluid aspirant. And then B shows a mom getting a transabdominal amniocentesis. And this is the amniotic fluid that they're pulling off. Indications for an amniocentesis. Typically, when we think there may be some genetic issues or genetic concerns, we will offer an amniocentesis. Women over the age of 35 are generally offered an amniocentesis, even if their maternal fetal markers or their triple screen or quad screen comes back normal. If there's a family history of chromosomal abnormalities, and anyone under the age of 35 who have abnormal maternal fetal markers such as a triple screen or quad screen, they're also offered an amniocentesis. The amniocentesis can be done later in the pregnancy, and usually when we do an amniocentesis in the third trimester, we're looking for fetal lung maturity. So we pull some fluid off, send it for an LS ratio. If the ratio is 2 to 1, we know that the lungs are mature and it would be safe to deliver the infant if there were any other problems concurrently going on. And to a lesser amount, we use it to diagnose fetal hemolytic disease. This is in your book. This is the biochemical monitoring. It shows the different maternal fetal markers. You'll hear me call them maternal fetal marker. You'll hear me call them biochemical monitoring, maternal blood assays. But basically, this is a list of the things we do. The Coombs test, if my mom is Rh negative, the alpha fetal protein, which tests for open neural tube or other defects. This is the LS ratio for lung maturity. And these are just a list of some of the biochemical monitoring that we do on our mothers who we're thinking there may be some type of high risk issue that may occur. Moving on to chorionic villus sampling, or CVS. The combined advantages of earlier diagnosis and rapid results have made chorionic villus sampling a popular technique for genetic studies. Although some risk to the fetus exists, although indications for CVS are similar to those for amniocentesis, second trimester amniocentesis appears to be safer than chorionic villus sampling. When performed after the first trimester, the procedure is better known as late CVS or placental biopsy. Chorionic villus sampling is performed between 10 and 13 weeks. We can do it earlier on because typically we can't do an amniocentesis until week 14. Chorionic villus sampling involves the removal of a small tissue specimen from the fetal portion of the placenta. Because chorionic villi originate in the zygote, this tissue reflects the genetic makeup of the fetus. This is figure 10-7 is showing a transcervical chorionic villus sampling. You can see the needle, and it's taking just a small piece of the chorionic villi. This is figure 10-8, and this is showing a transabdominal chorionic villus sampling. Instead of going through the vagina, they go through the wall of the abdomen to collect the sample. Percutaneous umbilical blood sampling, aka PUBS, or chordocentesis. This is the most widely used method for fetal blood sampling and transfusion. PUBS involves the insertion of a needle directly into a fetal umbilical vessel under ultrasound guidance. PUBS has been replaced in many centers by placental biopsy because it is a safer, easier, and faster alternative. Also, improvements in cytogenetic and molecular diagnostic testing have decreased the need for fetal blood samples. Many tests that were once performed using fetal blood can now be done using DNA-based analysis of chorionic villi. Indications for use of PUBS include prenatal diagnosis of inherited blood disorders, karyotyping of malformed fetuses, detection of fetal infection, determination of the acid-base status of the fetus with intrauterine growth restriction, and assessment and treatment of isoimmunization and thrombocytopenia in the fetus. Complications that can occur include leaking of blood from the puncture site, cord laceration, thromboembolism, preterm labor, premature rupture of the membranes, and infection. And this is figure 10-9 out of your textbook. It's a technique for percutaneous umbilical blood sampling guided by ultrasound. And you can see where the needle is actually going right into the umbilical cord. And typically they like to use the umbilical vein, which there's only one vein and two arteries in the cord. And the vein is usually bigger and easier to get to. This is figure 10-10 out of your textbook, and it shows the umbilical cord as seen on ultrasound at 26 weeks of gestation. Here you see the huge umbilical vein and then the arteries. One vein, two arteries. Okay, maternal assays. Maternal serum alpha fetal protein levels have been used as a screening tool for neural tube defects in pregnancy. Through this technique, approximately 80 to 85% of all open neural tube defects and open abdominal wall defects can be detected early in pregnancy. Screening is recommended for all pregnant women. Alpha fetal protein is produced by the fetal liver, and increasing levels are detectable in the serum of pregnant women from 14 to 34 weeks. Although amniotic fluid is diagnostic for neural tube defects, maternal serum alpha fetal protein is a screening tool only and identifies candidates for the more definitive procedure of amniocentesis and ultrasound examination. Maternal serum alpha fetal protein screening can be done with reasonable reliability any time between 15 and 22 weeks of gestation, with 16 to 18 weeks gestation being the ideal time to draw these labs. Other multiple marker screens. The ability of multiple marker tests to detect chromosomal abnormalities depends on the accuracy of gestational age assessment. These tests are screening procedures only and are not diagnostic. A positive screening test results indicates an increased risk, but is not diagnostic of trisomy 21 or another chromosome abnormality. Women with positive results should be offered diagnostic testing by amniocentesis or fetal blood sampling for fetal karyotyping. The Coombs test for Rh incompatibility is discussed later, but we'll talk a little bit about it now. If the maternal titer for Rh antibodies is greater than 1 to 8, amniocentesis for determination of bilirubin in amniotic fluid is indicated to establish the severity of fetal hemolytic anemia. Coombs test also can detect other antibodies that may place the fetus at risk for incompatibility with maternal antigens. Rh incompatibility is a condition that develops when a pregnant woman has Rh negative blood and the baby in her womb has Rh positive blood. And we'll talk about this later on when we talk about high risk issues in pregnancy. The cell-free DNA in maternal blood. This is a relatively new screening method for non-invasive prenatal genetic diagnosis. It's recently become available for use in the clinical setting. Cell-free DNA screening already provides a definitive diagnosis non-invasively for fetal Rh status, fetal gender, and certain paternally transmitted single gene disorders. Antepartum assessment using electronic fetal monitoring. Indications. During the first and second trimester, antepartum assessment is directed primarily at the diagnosis of fetal anomalies. The goal of third trimester testing is to determine whether the intrauterine environment continues to support the fetus. The testing is often used to determine the timing of childbirth for women at risk for uteroplacental insufficiency or UPI. Gradual loss of placental function results first in inadequate nutrient delivery to the fetus, leading to IUGR. Subsequently, respiratory function also is compromised, resulting in fetal hypoxia. The basis for the NST or non-stress test is that the normal fetus will produce characteristic heart rate patterns in response to fetal movement. In the healthy fetus with an intact CNS or central nervous system, 85% of gross fetal body movements are associated with accelerations of the fetal heart rate. The procedure. The fetal heart rate is recorded with a Doppler transducer, and a tochodynamometer is applied to detect uterine contractions or fetal movements. The tracing is observed for signs of fetal activity and a concurrent acceleration of the fetal heart rate. If evidence of fetal movement is not apparent on the tracing, the woman may be asked to depress a button on the handheld event marker connected to the monitor when she feels the fetal movement. The movement is then noted on the fetal tracing. Because almost all accelerations are accompanied by fetal movement, the movements need not be recorded for the test to be considered reactive. The test is usually completed within 20 to 30 minutes, but more time may be required if the fetus must be awakened from a sleep state. Interpretation of the results. The NST results are either reactive or non-reactive. Box 10-8 in your book lists the criteria for both results. A non-reactive test requires further evaluation. The testing period is often extended, usually for an additional 20 minutes, with the expectation that the fetal sleep state will change and the test will become reactive. During this time, vibroacoustic stimulation may be used to stimulate fetal activity. If the test does not meet the criteria after 40 minutes, a biophysical profile usually will be performed. Generally accepted criteria for a reactive tracing are as follows. In order for an NST to be reactive, there must be 2 or more accelerations. An acceleration is a raise in the heartbeat of 15 beats per minute lasting for 15 seconds over a 20-minute period. So for an NST to be reactive, I need 2 accelerations that are 15 by 15 in a 20-minute period. 2 or more accelerations. An acceleration is defined as an increase in the heart rate of 15 beats lasting for 15 seconds or longer. I need 2 accelerations in a 20-minute period. Also, there should be a normal baseline rate and long-term variability of about 10 or more beats per minute, and we'll talk about that later on this term. Vibroacoustic stimulation is another method of testing antepartum fetal heart rate response and is sometimes used in conjunction with the NST. We know the NST takes approximately 15 minutes to complete, with the fetus monitored for 5 to 10 minutes before stimulation to obtain a baseline fetal heart rate. And basically what a baseline fetal heart rate is, you take a 10-minute section of the fetal monitoring tracing and you see where the heart rate is at the most. We know that normal fetal heart rate is between 120 and 160. If the fetal baseline pattern is non-reactive, the sound source is then activated for 3 seconds on the maternal abdomen over the fetal head. Monitoring continues for another 5 minutes, after which the monitor tracing is assessed. A test is considered reactive if there is an immediate and sustained increase and long-term variability in heart rate accelerations. The accelerations produced may have a significant increase in duration. The vibroacoustic stim may be repeated at 1-minute intervals up to 3 times when there is no response. Further evaluation is needed with BPP or contraction stress test if the pattern still remains unreactive or non-reactive after use of the vibroacoustic stimulation. Now, just to kind of go over this again, a non-stress test is a test for fetal well-being. Basically, we put the mom on the monitor, and this is the tocodiameter. Typically, this goes over the fundus or the top of the uterus. And then this is the ultrasound that listens to the baby's heartbeat. And in your book, you'll see that the best place to find the fetal heartbeat is over the fetal back. So as an experienced OB nurse, before we put moms on the monitors, you'll usually see us palpate the abdomen to try and feel for the fetal back or fetal small parts. So if I know I have fetal small parts over here, I'll know that my back should be over there, and I would place my monitor on this area of the abdomen. So for an NST, like I said, we put the mom on the monitor. We are looking for accelerations with the fetal heart rate, and typically if the baby is active and moving, the heart rate should be accelerating. For my non-stress test to be reactive, I need 2 fetal heart rate accelerations in a 20-minute period. And for the acceleration to count, the baby's heartbeat has to rise 15 beats over the baseline and last for 15 seconds. So if I have a mom and I say her baseline is 120, in order for my acceleration to count, the heart rate has to get to 135 beats per minute or higher and last for 15 seconds. And when you're looking at the fetal monitoring tracing, 15 seconds is like a box and a half, 1.5 small boxes. 2 and 20, 15 by 15. 2 accelerations in a 20-minute period, 15 beats above baseline, lasting 15 seconds or longer. So here's an example of a reactive NST. Right now it doesn't look like she's having any contractions, or it really doesn't look like they even have the toco on, but these spikes you see here is whenever the mom feels fetal movement, there's a button attached to the monitor. They push the button, and when you see the spikes, you should see an acceleration. This is when the mom feels the baby move. So if we're looking right here to try and find a baseline, I would say the baseline for this baby looks to be about 125. So now I need to look for 2 accelerations, and we say an acceleration 15 beats above baseline, lasting 15 seconds. If I'm saying my baseline is 125, that means the heart rate needs to be 140 and above. Right here is the 140 line. There's the 150 line. And I said 15 seconds is about 1.5 small boxes. So right here would be a perfectly good acceleration. And you can see this one went almost, look, to about 180. And there's 10, 20, 30, 40, 50, about 60 seconds. All I need is 15 by 15. Right here we have a perfectly good acceleration. I would call this an acceleration. I would call this right here an acceleration, and one more right here towards the end. So all I need is 2 in 20 minutes. And right here, like I was telling you guys, when you're at the hospital, you can see the dark lines. From dark line to dark line is a minute. So this tracing is probably 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So this is about an 11 or 10 minute piece of tracing, and already within the first 10 minutes I have a reactive NST. Even though the first 10 minutes is reactive, we still leave the mom on for a total of about 20 minutes. This is an example of a non-reactive NST. Here you have the spike showing that the mom is saying, oh, I felt the baby move here, 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 and here. But when you look at the heart rate, you really don't see an acceleration or an increase in the baby's heart rate. This heart rate is staying around 140, 145. Although the mom says she's feeling movement, I'm not having the corresponding acceleration with the movement. So this would be a non-reactive NST. Here's another non-reactive NST. It shows the mom's not contracting, but this baby, it's almost a flat line. And in OB, we say the variability is decreased because you usually want to see more up and down spikes, but this baby is kind of staying right there around 130. So this is another non-reactive NST. Now, this is an NST, and right here we can see the baseline is about between 120, 130. Probably, I'll say right in the middle of 125. Here's an example. Here's the mom. She pushed the button, said she felt movement, but of course we don't see a rise in the heart rate there. But look at this. This is the nurse showing that, ooh, I did vibroacoustic stimulation, and look how my baby reacted to it. This baby went from being kind of, oh, I'm just here lounging around doing nothing. Then the nurse does the vibroacoustic stim, kind of startles the baby. The baby moves, and we get a good old rise in the heartbeat. So that's a good acceleration. So usually when I have NSTs that are starting off kind of like this, I would either give the mom a snack, maybe a juice. Usually we loved orange juice if they weren't diabetic, and some graham crackers. Or I could do the vibroacoustic stim to get that baby to get up and move. And like I said in the earlier slide, we're only allowed to do this 3 times. And if the baby makes no apparent movement or increase in the heart rate, we get a little concerned. And after the 40-minute time was up, we would probably we would send that mom for a biophysical profile. All right, the next test we're going to talk about is the contraction stress test, or CST. The contraction stress test, or you'll also hear it called the oxytocin challenge test, was the first widely used electronic fetal assessment test. It was devised as a graded stress test of the fetus, and its purpose was to identify the jeopardized fetus that was stable at rest but showed evidence of compromise after being placed under stress. Uterine contractions decrease uterine blood flow and placental perfusion. If this decrease is sufficient to produce hypoxia in the fetus, a deceleration in fetal heart rate results. And a deceleration is basically the opposite of an acceleration. With an acceleration, the heart rate goes up. With the deceleration, the heart rate goes down. And we'll talk about the different types of decelerations later on in the term. But just for a quick little review, there's 3 types of decelerations we have. We have early decels, late decels, and variable decels. Early decels are caused by head compression. Late decels, which are the ones we worry about the most, are caused by uteroplacental insufficiency. And like I said, my placenta is my baby's lifeline. So if that placenta is not working accurately or up to par, I'm going to have a baby in some form of fetal distress. And then your variable decelerations are caused by cord compression or compression of the umbilical cord. The contraction stress test provides an earlier warning of fetal compromise than the non-stress test and produces fewer false positive results. However, the contraction stress test is more time-consuming and expensive than the NST. It is also an invasive procedure if oxytocin stimulation is required. In general, the contraction stress test cannot be performed on women who should not give birth vaginally at the time the test is done. Absolute contraindications for the contraction stress test are the following: preterm labor, placenta previa, basa previa, reduced cervical competence, multiple gestations, and previous classic incision for cesarean birth. Because of these disadvantages, the contraction stress test is used infrequently. The interpretation of a CST. Now, unlike the NST, your CST, if the results can be negative, positive, equivocal, suspicious, or unsatisfactory. If no late decelerations are observed with the contractions, the findings are considered negative. So a negative CST is a good thing. It means my baby will be able to handle stress of labor and that they have plenty of reserve and that their placenta is still functioning correctly. Repetitive late decelerations render the test positive. So a positive CST is not a good thing. Table 10-5 in your book lists criteria for each possible test result and the clinical significance of each. The desired contraction stress test result is negative. We want a negative CST because it has consistently been associated with good fetal outcomes. The likelihood of fetal death occurring within 1 week of a negative CST is less than 1 in 1,000. Now, how do we administer a CST? Basically, there's 2 different ways we can do it. One way is invasive, and that's when we have to start an IV and start oxytocin or pitocin drip on the mom. Or we can do it without being invasive, and we can do nipple stimulation because nipple stimulation releases oxytocin from the posterior pituitary gland, and we know oxytocin is what makes the uterus contract. So basically what I do, usually we'll get an NST first just to make sure the baby's not having any late decelerations before we even start the pitocin. So I'll monitor the baby for about 15-20 minutes. Then what I do, I start my pitocin drip. And I would do my pitocin just like I'm trying to get the mom into labor, because what I want to get 3 contractions in a 10-minute period. So I increase the oxytocin or pitocin until I get the mom to have 3 contractions in a 10-minute period. When I get the mom contracting where she's doing at least 3 in a 10-minute period, I then will look at the baby's heart rate to see how the baby handles the contractions. So when you're looking at figure A, there's 1 contraction, 2 contractions, and there's the 3rd contraction. And what I want to look at is with each contraction, does my baby's heart rate drops? Or does the baby exhibit a late deceleration? And for this one, this is absolutely no decelerations. So this is a negative CST. And remember, I said a negative CST is a good thing. Now, on the other hand, in B, this tracing here, I have my 3 contractions, but if you look at each contraction, look how the baby's heart rate goes down. It comes back up. Oh, there's another contraction. Look, it goes down again. It's back up to normal. Here comes another contraction, and you see the heart rate dips there. Also, here's another one where the fetal heart rate starts to drop. Basically, with each of these contractions, this baby had a late deceleration. And the way that I know it's a late deceleration is the heart rate starts to go down after the peak of the contraction. So there's the peak or the acme of my contraction. You can see the heart rate goes down each time. Boom, boom, boom. So right there with each of those contractions, this baby had a late deceleration. This makes this CST positive, and a positive CST is a bad thing. This baby is not going to be able to tolerate the stress of labor. They have very little fetal reserves left, and this is a baby, when you see late, you see decelerations. You know when you see late decelerations that's caused by uteroplacental insufficiency. My placenta's not working well. My baby's not getting perfused well. My baby is in some type of distress. Did I say that enough? Negative CST, good. Positive CST, bad. Reactive NST, good. Non-reactive NST, not completely bad, but we have to do further testing. We follow up a non-reactive NST with a biophysical profile. Okay, the nurse's role in assessment of the high-risk pregnancy. The nurse's role is primarily that of educator and support person when the woman is undergoing exams such as ultrasound, MRI, CVS, or PUBS, and amniocentesis. In some instances, the nurse may assist another healthcare provider with the procedure. In many settings, nurses perform NSTs, CSTs, and BPPs. They conduct an initial assessment and begin necessary interventions for non-reassuring results. These nursing procedures are accomplished after additional education and training under guidance of established protocols and in collaboration with obstetric providers. Patient teaching, which is an integral component of this role, involves preparing the woman for the procedure, interpreting the findings, and providing psychosocial support when needed. Okay, here's a question. The volume of amniotic fluid is an important factor in assessing fetal well-being. Oligohydramnios, or too little fluid, is associated with what kind of fetal anomaly? A. Renal, B. Cardiac, C. Gastrointestinal, D. Neurologic. The correct answer is A. Renal. In the feedback, an amniotic fluid volume of less than 300 mL is associated with fetal renal anomalies such as renal agenesis. Option B is incorrect. The amniotic fluid volume has no bearing on the fetal cardiovascular system. Answer C is incorrect. Gastrointestinal anomalies are associated with hydramnios, or too much fluid. And D is incorrect. The amniotic fluid volume has no bearing on the fetal neurologic system. This concludes the audio lecture for Chapter 10, Assessment of High-Risk Pregnancy. Thank you.